multiple gestation, previous preterm labor, smoking more than 10 cigarettes a day, chronic physical or psychological stress,
diethylstilbestrol,
DES exposure, alcohol or substance abuse, uterine surgery or anomalies, infection, hydramnios, inadequate nutrition, and anemia. Look for 7 warning signs of preterm labor. They are regular uterine contractions every 10 minutes or more often, with or without pain, intestinal cramping, with or without diarrhea, menstrual-like cramps, low backache, pelvic pressure, change in vaginal discharge or bleeding, and premature rupture of membranes. If your client has these signs and symptoms, she will be admitted to the labor and delivery unit for continual electronic fetal monitoring. The diagnosis of preterm labor is made when uterine contractions are documented as 4 in 20 minutes or 8 in 60 minutes. The other defining characteristics is that the cervix is approximately 80% effaced and dilated 2 or more centimeters. What is your role in managing a client with preterm labor? When a client comes to the hospital, possibly in preterm labor, you will check her for frequency, duration, regularity, and intensity of uterine contractions. You will also check to see if she has ruptured membranes. If she is having regular contractions or her membranes have ruptured, admit her to the labor and delivery unit and keep her on bed rest in the left lateral position. Start an intravenous infusion to maintain her hydration. If sedation is prescribed and administered, be sure to follow the appropriate safety measures. When preterm labor must be stopped, contraction-inhibiting medications called tocolytics are administered. You'll watch your client closely for side effects, such as chest pain, shortness of breath, pulmonary edema, and maternal tachycardia. Also monitor her electrolytes and blood glucose levels, as these drugs can cause hyperglycemia and hypokalemia. If delivery is imminent and the fetal lungs are not yet mature, or gestation is 33 weeks or less, she will also be given betamethasone, a corticosteroid, to accelerate fetal lung maturity and reduce the infant's risk of respiratory distress syndrome. If the client is experiencing signs of preterm labor at home, advise her to maintain bed rest until her symptoms subside. Advise her to drink 2 to 3 glasses of water or juice, avoid sexual intercourse, and call the physician or midwife if she continues to have 5 or more contractions per hour or other symptoms of labor that do not go away or return. Also instruct her that if she has a contraction every 5 minutes or more frequently, vaginal bleeding is evident, her vaginal discharge has an unusual odor, or fluid is leaking from her vagina, she must call her healthcare provider immediately. The tocolytic drugs given to suppress or stop uterine activity are ritodrine, terbutaline, beta-adrenergic agonists given intravenously, subcutaneously, or orally. Magnesium sulfate is often given intravenously to depress uterine contractility, as it causes fewer adverse effects than the beta-adrenergic agonists do. With magnesium sulfate, monitor for decreased urine output, blood pressure, reflexes, and respirations. Other medications used to suppress labor are calcium channel blockers, like nifedipine and prostaglandins inhibitors. What are the potential complications of preterm labor? Besides maternal side effects of the medications, common complications of preterm labor for the infant include respiratory distress, hyperbilirubinemia, and infection. How would you prioritize the following interventions for preterm labor? For a client in preterm labor, you would first start the IV and infuse the prescribed tocolytic, then administer betamethasone, then apply a fetal monitor, and then teach the client about the importance of bed rest. The rationale for starting the IV and giving the tocolytic first is that hydration and medications are used to stop preterm labor. This is the top priority. Betamethasone is given next, because if your client continues to labor and does deliver in the next 24 hours, this will help develop the baby's lungs. Next is applying the fetal monitor so that you can evaluate the status of the client's contractions, as well as the fetal heart rate pattern. Finally, teaching about bed rest, and although it's important, is not the immediate priority. In actual practice, however, you'll perform all these interventions in a rapid succession and in a matter of minutes. What is your role in managing the post-term client? Just as you will care for the clients in preterm labor, you will also encounter clients whose pregnancy is post-term. This means that the pregnancy is extended beyond 42 weeks gestation. As the post-term fetus might be excessively large, your client is at risk for dysfunctional labor and lacerations, induction of labor, forceps or vacuum-assisted delivery, and C-section. Obviously, an accurate determination of the due date is important when evaluating the post-term pregnant client. After the 41st week of gestation, the placenta ages and declines in function. It's almost as though the placenta comes with a 1 to 2 week extended warranty. After that, oxygen and nutrient supplies to the fetus are altered, and the fetus is at risk for fetal distress during labor. That distress can take the form of asphyxia, meconium aspiration, dysmaturity syndrome, and respiratory distress. In addition, amniotic fluid volume declines dramatically between 40 and 42 weeks of gestation, increasing the likelihood of hypoxia resulting from fetal cord compression. Keep in mind that the post-term fetus is at an increased risk for neonatal mortality. Compounding the situation, many women become anxious about going past their estimated delivery date. Risk factors associated with post-term delivery are previous post-term delivery, estrogen deficiency, and adrenal cortical insufficiency. Look for signs that the pregnancy is post-term, such as oligohydramnios, fetal distress, or a significant decrease in fetal activity. Your post-term labor interventions include teaching the client about the possibility of inducing labor using oxytocin. Prepare her for the possibility of forceps-assisted, vacuum-assisted, or cesarean delivery. Be aware that oligohydramnios is common with post-term labor, so an amnio infusion is sometimes done to restore volume. Assist with setting up and explaining this procedure to the client and family. Meanwhile, continue to monitor the fetal heart rate for decelerations, and be sure to anticipate respiratory problems in the newborn. After the baby is born, test the infant's blood glucose within 1 hour of delivery. To prevent hypoglycemia,